Hey, girl gang, it's Dr. Joy here, and you are watching Delivering Joy MD TV. Welcome to Well Woman Wednesday. Today, I have a wonderful surprise for you. We know that it's coming up on Black Maternal Health Week. That's going to be April 11th through April 17th. And I have one of the gurus in Black maternal health today. She is somebody you definitely want to hear from. Make sure you keep watching. All right, we're back. And today I have one of my former teachers, mentors, and just all around cool girl gang members, Dr. Zsakeba Henderson. Dr. Zsakeba Henderson is the principal consultant at ESW Consultants, and she is a national expert in leading and inspiring teams to improve outcomes in maternal and infant health. Currently, she serves as the Senior Health Advisor for the National Institute for Children's Health Quality, which is, one of those big organizations that is doing great work. And so I am absolutely ecstatic to have you today, Dr. Henderson. Thank you so much for joining me.
Oh, it's such a pleasure to be with you, Dr. Joy. I have been following you. I'm a fangirl. I've been watching what you've done and how you're growing your influence for the health of moms and babies in our country, and just so excited to be here to join you today.
Well, I am definitely a fangirl as well. You may or may not remember this, but back in 2009, 2010, you were teaching at the Morehouse School of Medicine OBGYN residency program. So I was a baby doctor then, like a little baby doctor. And one of the presentations you gave us about maternal mortality, even back then, because at that time, I think you were with the CDC and you guys were collecting data. So you've been in this work a long time, but you definitely inspired me. And I remember listening to you and thinking, this is not how this should go. This is not where Georgia should be. This is not where the United States should be. And so I have always followed your work and just been such a big fan. And so I'm so grateful that we have an opportunity to talk about this. And, I think with these conversations, we hear so much about the statistics, and the statistics are important. But one of the things that I've seen you bring in your work is to talk about solutions and how do we get to a better place. So I'm getting excited and ahead of myself. So let's start out, I guess, with a little bit of the numbers. I want to make sure we kind of lay out the framework for what's happening right now in maternal and infant health, and particularly Black maternal and infant health.
Yeah, the numbers are so important. And you didn't tell my age, but yes, I have been doing this for a while. And I started off just my interest in maternal health started at the Centers for Disease Control and Prevention. And as you mentioned, I was deeply engaged in the surveillance system that we have, one of the surveillance systems to sort of count and measure what's happening with maternal deaths, known as the Pregnancy Mortality Surveillance System. There are different ways that we measure what's happening in our country around maternal deaths. Is that surveillance system, and then there's sort of the passive collection of vital statistics through our National Center of Health Statistics. And the way we look at maternal deaths is very different in those two systems. The National Center for Health Statistics looks at a maternal mortality rate, and this rate is something that's comparable to what's measured in other countries, and it looks at deaths to mothers due to complications of pregnancy or due to an aggravation of a condition from pregnancy. So we look at cases where if that woman was not pregnant, she would not have died. So any deaths that we think are due to an aggravation of a condition from the pregnancy. And they only look at that rate for the maternal mortality rate. They look up to 6 weeks or 42 days after the pregnancy. So the maternal mortality rate is something that we can use to compare internationally to see where our country stands when comparing with other countries. But then there's a surveillance system. Surveillance system is the active collection of data. Instead of just collecting vital statistics, the pregnancy mortality surveillance system looks at death from death certificates, but also compares it to confirm that the women were pregnant, compares it to fetal death and birth certificates. So we have additional data that shows the timing of the death from the time that the woman was pregnant. And the interesting thing about that system is that it recognizes that these deaths due to complications of pregnancy can be up to a year after the completion of the pregnancy. So the data from the the pregnancy mortality surveillance system measures what's called pregnancy-related death, and it's a more complete measure and gives us a better picture of what's really happening in terms of deaths. There's sometimes that vital statistics may miss some deaths. There may be things that are miscoded on the death certificate that are picked up in that surveillance system. And what I can say, even before I started looking at this, things weren't great in our country when you compare it to others, but it has definitely gotten worse. And most people are not aware that the United States is the worst place to be born and give birth compared to other industrialized nations. We have the worst rates of deaths to pregnant people in this country than in any other wealthy nation. And that is just not acceptable. And that's just overall. When we start to look at the disparities, it's even more alarming.
And, that to me is such a shocking statement, because when we think about the United States of America, we think about the top nation, the leader of the pack, but we really haven't done well in our abilities to care for moms and babies for years now. Because I remember, I'm not going to tell my age either, but I mean, when I first heard you talk about this, it was at least 13, 14 years ago. Yep. So we've only gotten worse in that time. So that's scary. And then we think about our state of Georgia being in the bottom tier in the United States. So that means that if we're living in Georgia, that this may be one of the worst places in the developed world to give birth. Wow.
Absolutely. In Georgia, from what I last recall, Georgia was like 48th or 49th out of 50.
Right. We're 48th and Louisiana is behind us.
I knew Louisiana and Mississippi are kind of at the bottom, and then comes Georgia.
Right. So it's like,
but it's not good. I'm so glad that more attention is being paid to this issue. But as I mentioned, this is not new. We've had decades and decades of just things not, the rates for a while when, different medical interventions and innovations came on board, maternal mortality decreased for some time. But when we look at from about 1940s to now, the disparities, particularly the disparities between Black mothers, American Indian, Alaska Native mothers, and then compared to white mothers have been alarming, the gaps. For that, it's been about 60, 70, 80 years where we've had consistently Black moms have been 2 to 4 times more likely to die than white mothers in this country. So it's not a new issue, but the problem is that it's not getting better. It's getting worse. It's going in the wrong direction.
So, you've been watching this data for a long time, and you probably are more familiar than many of the folks that we hear from in the media and, on social media in particular. Why do you think these disparities exist when it comes to Native Americans and Black women? Where do they come from?
Well, to be honest, a lot of people have been trying to speculate. I know during the time I was at CDC, we went from looking at potentially biological or environmental or other socioeconomic contributions to the disparity. But when you look at the disparities, when you look at these deaths, one of the things to pay attention to is what the causes of death. So the causes of death are a little bit different when you look at overall top causes of death, and then when you break it down by specific racial, ethnic categories. Overall, right now in this country, the top causes of death are mental health. So that includes drug overdoses, suicide, and then you have what we call, conditions related to the pregnancy. So there are conditions such as, preeclampsia, hemorrhage, blood clots. But when we look at the causes by race, ethnicity, the top cause of death among white mothers is mental health. When we look at for Black mothers, it's cardiovascular causes. So that includes complications of, preeclampsia, and eclampsia, so heart attacks, cardiomyopathy, congestive heart failure. Those are the main causes for Black mothers. And then when you look at American and Alaska Natives, the top causes like hemorrhage, things that are totally preventable, are the causes of death. But when you look at even the prevalence of these conditions and compare it between Black mothers and white mothers, so there was a study done not long after I started working at CDC. It was like early 2000s that looked at the causes of death, the common causes of death among Black mothers and white mothers. They looked at top 5 causes of death. And they wanted to see if Black mothers are dying more because they get these conditions more often, or is the prevalence of these conditions higher among Black women? And they noticed that Black women don't get these conditions more frequently than white mothers, but they're more likely to die from them. So that says a lot. So either the severity of their illness is worse where they die, either the response or how it was treated may not have been optimal. And as we look at data now, and we look at causes of death, and we look at, there's really no difference when you look at socioeconomics or education, because when you look at a Black woman who has maternal mortality, who has a Black woman that has education higher than college level education. So a PhD or a doctor who is a Black woman has a higher risk of dying from pregnancy than a white woman with less than a high school education. So we know it's not socioeconomics. We know it's not education. We know it's not that they are more frequently diagnosed with certain conditions. But then there's been more work done in the area of quality, looking at how we treat conditions and looking at issues around quality and safety. And there's data that shows that the way we treat and respond to Black mothers and American Indian mothers and the access that they have to certain life-saving therapies is different than for white women. For example, there are studies looking at severe maternal morbidity and mortality, looking at hospitals that primarily serve white women and hospitals that primarily serve Black mothers. And they noticed that not only were there differences between those hospitals because some of these Black serving hospitals had less resources than the white hospitals, but even when you looked in the same individual institutions and you compared Black and white mothers, there was higher morbidity and mortality from the same conditions among Black mothers. So that leads us to understand that there's something other than what's, genetic or biologic, or even the conditions that Black people and Native Americans are dying from that aren't different than white people. It really comes down to other factors that we know that are more structural and systemic. And I'm so excited and happy that we're finally acknowledging that there's a difference in how Black and Native American mothers engage with the healthcare system. We know that there are differences in access. We know that there are absolutely differences in quality of care. There are issues with delays in diagnosis. We know that, there are many, many episodes or incidences where Black mothers that have complained of certain problems during pregnancies that have been ignored, or where they haven't been listened to. When we think of some of the most high profile cases, like we think about Serena Williams, someone who definitely has all the resources in terms of having access, in terms of being fully educated and knowledgeable of her condition, and they didn't listen to her. Right. And she could have died from she had pulmonary embolism. And then there are many other cases that we see in the news. One of my former colleagues, Shalon Irving, that was a case of she had sought care on multiple instances and was sent home and ended up dying at home. There are others, thinking about Kira Johnson, who had delays in diagnosis of hemorrhage. So we know that there are problems in terms of the care that's provided, the quality of care that's provided, how Black mothers and American Indian and Alaska Native mothers are treated by our healthcare system.
When we talk about that quality, how do we know, what sort of measures are put in place to help us know how to choose the right places? You know what I'm saying? And figure out how to get the best quality for ourselves when we're going in to access the healthcare system.
That's a great question. Excuse me. And I think that there are systems and things being put in place to help Black mamas to know where they can get the best care. One of the things that comes to my mind immediately is the Irth App that was developed by American
really
Nation, led by Kimberly Seals Allers. And one thing that's beautiful about that app is that you get to get a snapshot of the type of care that others have received from certain institutions. You get input from patients, their family members, community birth workers that tell the real deal about how patients are treated in certain hospitals and institutions. There are also other things that you can look at. There are measures that even, the Joint Commission, which accreditates many of the hospitals in our country, and the Centers for Medicaid and Medicare services that look at the quality of care, certain measures, for example, C-section rates, measures around, timely treatment for blood pressure, severe blood pressure, hemorrhage. And some of these things you can actually access as a consumer. For example, in California, you can go to Yelp and see which hospitals have the highest C-section rates.
Wow.
The CMS even has a website called Hospital Compare that shows some of those measures by hospital. So consumers do have, access to information about providers through some of these apps where you can share your experiences, and also some of the measures of the hospitals where they receive treatment and how well they're doing.
So for the average person who's watching, I always like to try to, talk to families about just, what questions you need to ask when you're looking at a provider, when you're looking at a delivery option, what sort of things to ask. And I think that's important to know, because when you talk about people dying of hemorrhage or hypertensive crises or cardiovascular disease that may have been caused by preeclampsia, it's important to know if your hospital has implemented the safety bundles and if they use that with every patient every time. I think those are questions that we should be asking. What are some of your thoughts around how families might ask the right questions so that they can find the right provider and the right OB care team for them?
I think one of the things that is really important for patients to understand when they're seeking a provider, I think it's important for them to understand how that provider engages with their patients. One of the terms that has come into popularity recently is respectful care. One of the problems with patients not being heard and not listened to is that there is this patriarchal environment that we have in medicine where doctors feel like, we make the decision, you need to listen and just do what we say. When in actuality, it should be a situation where there is shared decision-making, where patients have questions answered and are fully engaged with the decisions that are being made in their care. And so it's some of those sites, for example, the Irth App and other ways of looking at reviews, is important to understand before choosing a provider how they engage with their patients and knowing how they respect their patients. But then there should always be, patients should always be empowered to ask questions and to understand why decisions are being made. Unfortunately, I had an experience very recently with a young lady who ended up actually on my husband's service, inpatient service, who was out of town. She was from Alabama, was in Georgia, admitted in a hospital. And my husband always gets, curbside consults with me sometimes when he has pregnant patients. And come to find out, this young lady received some of the most disrespectful care that I've ever personally witnessed. And I was so compelled to stay engaged with her through the remainder of her pregnancy. One, I wanted to help her find a new provider. And unfortunately, because she was so far along, she couldn't get a new provider. But one of the things that was so alarming and eye-opening during that experience is I was first able to witness from her perspective, from the patient perspective, what happens when you ask questions. What happens when you press and want to understand why decisions are made? And unfortunately, there are a lot of providers in our country who don't receive questions so well. They feel like they're being threatened when they're being questioned. And this young lady was actually wanted to dismiss her from the practice because of all the questions she was asking. Can you believe that?
Wow.
But despite that, I think patients should be empowered. You have to ask questions. Have those, I think it's important to have support people, whether it's your partner, another family member, a doula, someone else to help, make sure that you fully understand everything that's being done and that you're being heard. And it's unfortunate that we have so many providers in our country who follow this, do what I say and don't question me, type attitude. And I think even more in this environment of increasing maternal morbidity and mortality, patients need to feel fully empowered to make sure that they're heard.
I totally agree. And some of the training that we have as medical providers, we're always thinking about these things, going down decision lanes, saying, okay, if this happens, then I do this. And if this happens, then I do that. And we sometimes forget to involve our patients and their supporters in that decision-making process. And I think that's very important. And, I absolutely agree with what you say about patriarchal medical care, because, I have even caught myself saying, well, I'm going to do this. Saying, actually, let me explain why I think we should do this, and you tell me if it's okay. You have to kind of walk that back and start to police that, because it is, you're making these decisions. You think you know what needs to happen, but I'm not an expert on everybody else's body. Now, we know a lot about the body. We are trained to understand how it works, but really that birthing person is the expert on how they feel. They understand what their needs are, and they can tell you if you are willing to listen. And I think that a patient who is empowered to ask questions is actually a patient who is going to likely have better outcomes, because they are paying active attention in their appointments. They are paying active attention during their birth. So those folks, I think, are actually refreshing versus, annoying. Like, I don't think I could ever even have an idea to dismiss someone for asking questions. That's just so interesting to me.
It was horrible. Like, I think the problem was the patient was asking for a consultation with a high-risk OB, which she was totally due, because she had a twin pregnancy that was complicated by hyperemesis. And so she was in and out of the hospital with dehydration. She had poor weight gain. The babies weren't growing well. She should have had a high-risk consult. And these doctors were so offended by the fact that the team in the hospital where she was admitted to had suggested she see a high-risk doctor. And she told her doctor she wanted to see a high-risk doctor. And they took it at that she wanted to leave their practice. And she was asking questions and like, I need a consult. Like, what you're doing is not working. And they took offense to that and wanted to dismiss her from the practice.
Wow.
It was just
absolutely amazing to me. Like, I can't, people who are being active should not be a nuisance. They should be people that we actually take a little bit more time with and explain things. And we should explain to every patient, but folks who are actually questioning and seeking knowledge, then absolutely. Wow. That's a big one. So, I hate that Black and brown folks need to know how to advocate for themselves within systems. I hate that that is the case, but I think it is very important. And, when we start to turn our thoughts to how we improve these outcomes within healthcare systems and within communities, right? Because people don't live in the hospital, they live at home and they live in their communities. And sometimes it is necessary that our community be able to recognize warning signs and help us get to the right place. When you start to think about this, because I know you're the boss lady over at the National Institute for Children's Health Quality. So when you're turning your thoughts to how are we going to fix this, what are some of your ideas? I know I saw this infographic on LinkedIn that looked pretty amazing. So talk about a little bit about how you're planning to move our country forward with regards to children's health quality.
Well, we know that, one thing I have to get on my soapbox, because we talk about maternal mortality and then we separate and talk about infant mortality. But I just want to share and make sure people understand that it's the same problem, that it's a continuum, that what happens to mom impacts what happens to baby, and what happens during that pregnancy impacts the mother's health. And so we talk about preterm birth, we talk about infant mortality, some of the same drivers, some of the same factors that contribute to maternal deaths and maternal morbidity, which is even a bigger problem than maternal death, are the same factors that lead to the increased rates and disparities that we see in infant mortality. And we know that it's multifactorial. We know that where people live, work, play, where they, whether they have transportation, all of those social factors contribute to outcomes. We know that for certain. We also know that there are factors in the whole life course in terms of health. Making sure that people have the optimal health and optimal management of chronic conditions prior to becoming pregnant is also important. But we also know that the healthcare system, while it's just a stop along that continuum, is a huge contributor to what happens. We also know from recent data from the CDC that more than half of the maternal deaths that we see happen within 7 days after pregnancy up to a year. So the large majority of deaths happen after the pregnancy is over. So there are so many factors that, whether it's access, whether people understand warning signs, whether they have the support that they need, whether they are being heard within a clinical setting, and any conditions are diagnosed in a timely fashion and also adequately managed. These are all multiple factors that contribute to these causes. So when we look at solutions, we have to look at all of those factors. So we have to look at community-based solutions, making sure people have community-based supports, making sure they have access to care once they leave the hospital, making sure they have basic things like food and transportation and housing. We also need to look at our healthcare system as well in terms of the quality of care. We think of healthcare system as access and quality. So there are interventions that we use too much, and then there are interventions that we don't use enough, and making sure that that best practices, things that we know are the best things to do, are happening for every single patient every single time. So when we look at solutions, they sort of fall in those buckets. They're policy-based solutions. People don't have access because they may be uninsured. Or we have this issue with providers in our country. We have reduced workforce. Over 50% of counties in our country don't even have an obstetric provider, and that includes obstetricians and midwives. So we have to address the issues around workforce. We have to address issues around insurance. So policy issues around that. Issues around support and making sure people can afford that support. So policies around making sure doulas are available and they are reimbursed for their services. In terms of workforce, we have to fully recognize that midwives are part of the birthing team. And in every other country that has better outcomes, better maternal outcomes, they have large and mobile midwifery workforces. In our country, midwives have been marginalized, they've been sidelined, and they've sort of been disenfranchised in terms of their autonomy in practice, and also being able to be the supports that many mothers who have no complications in their pregnancy need. So there are so many different solutions, and I can go on and on, but the main buckets I would put them in is one, there are policies that we can be engaged in. There are community-based interventions and supports. We need more research on how to address, certain conditions and getting better treatments. And then we have to address the quality of care that we provide in our healthcare systems.
Definitely three big things. And I know that research is one really exciting field. I never thought I would be interested in research, but over the past couple of years, I've become increasingly interested and have done several projects. And one part of the research that I'm very interested in is actually what we call qualitative research, which means actually hearing the voice of the patient, understanding the experience of the patient, going back and doing chart reviews and understanding the rationale for why this patient was given a particular treatment plan versus another plan. So these things I find very interesting because I think this is how we identify some of the underlying causes, particularly within the hospital system, and then start to work on process change. So I've gotten very interested in quality improvement. And one thing I was hoping that you might share with us, because I know you get to visit different maternal mortality review committees and quality improvement collaboratives. Can you give an example of one that you've seen that you think is working really well and that has started to actually move the needle on driving change?
Absolutely. So you brought up, first, I just want to address your point about getting that qualitative data is so important. And you mentioned maternal mortality review committees. And basically, the value that those committees bring is that they go beyond the numbers. Like, we have these surveillance systems looking at the statistics, but behind those numbers are people. They are someone's mother, someone's sister, someone's partner who are gone. And more than 80% of those deaths are preventable. So being able to delve into the qualitative, the story, the narrative of why this person died is so, so important. And one of the things that I was really excited to be engaged in while at CDC is being able to make that link between that qualitative important data that maternal mortality review committees are getting and using that data for improvement through the state perinatal quality collaboratives. Collaboratives and maternal mortality review committees had been working in isolation, but they had all this rich data from maternal mortality reviews and even recommendations that weren't being fully implemented. And I looked at PQCs as the implementation arm of the maternal mortality review committees. And there are many states that are actively engaging that work where they're using the information and recommendations from maternal mortality review committees to guide their improvement efforts. So to prioritize which conditions they're going to address in their improvement efforts, using some of the recommendations that were given from maternal mortality review committees as interventions as part of their improvement efforts. And there are many states that are doing great. I hate to call out names because I'm going to leave someone out, but one state that stands out to me, and the reason why they stand out to me is because they've been innovative and they've also had statewide engagement, like every maternal hospital in the state is engaged, and that's the state of Illinois. And Illinois has done some really great work. They've done work around substance use disorder, improving access to medication assisted therapy for those who have opioid use disorder, improving the transition from hospital to community, making sure that patients have access to community-based resources. They've expanded their work around improving timely identification and management of those with severe hypertension and making sure that patients are treated in a timely fashion, which also led to a decrease in the amount of severe morbidity that they've seen in that state. And then most recently, they have done a statewide effort looking at respectful care and birth equity, and also looking at social determinants and making sure patients who do have gaps in terms of their social, the resources they have, like where they live, whether they're insured, whether they have food security, having access to resources once they're discharged from the hospital. And I think that that's been one successful example, but not the only one. Louisiana, they've been doing some really great work. Combining the amazing data from their maternal mortality reviews and using that to guide their improvement efforts there, and looking at specific interventions to narrow the disparity gaps there. New York State has been working hard. In New York, they really need to work hard because they've had some really bad problems with maternal mortality in that state. But they have been actively looking for solutions to improve respectful care, but also to address some of those top causes of mortality and morbidity in that state. So there are many examples. We haven't, gotten to the point where we've solved the problem, but I think once we recognize that this is not a one solution problem, there are many factors that will have to come together to really make a difference. And fully recognizing that we need the input and resources of multiple partners to really make a difference. It's not going to be one person or entity that's going to solve this maternal mortality problem. I think that we'll make some real change with these ongoing collaborations that are happening.
I'm very excited to hear about that. Georgia has our perinatal collaborative meeting coming up in a couple weeks, and I'm going to be excited to be there. And I know that one of the things we're working on in Georgia actively is getting the cardiac health bundle.
Yes, one of the first states to tackle the cardiac disease.
And it is huge. It's huge. The bundle has so many moving parts to it, and we've been working on it now probably about a year. So there's so much work that's being done. And one thing I think that we have to be careful about is not working in silos. Like you talked about, you had a maternal mortality review committee and then a quality collaborative, and they're just kind of working separately. But really, we need to be integrated. And I love how I'm seeing, I saw that the Black Mamas Matter Alliance is starting to do some work with the maternal mortality review committees and talk about how they can translate some of their recommendations and their findings to the community so that they can kind of translate from all of the medical terms into things that communities understand, so that people are able to get this information to understand how we're working to change these things, but also understand how, as a community, they can engage with their birthing folks and be able to, say, oh, okay, I remember that I read about preeclampsia and I see that you're swelling and you have headaches. So let's take you to the hospital and get checked out. And let's make sure that we have an opportunity to seek care and to advocate for quality care while we're there. Because we know a little something. And when you know something and you know better, you can do better. Right.
Absolutely. Absolutely. And I think it's great that, the collaboratives are starting to transition and recognize the community-based wisdom and input. Many of the solutions are already out there. We just need to listen and to engage, the community-based efforts. There's a huge gap between what's happening in the communities and what's happening in hospitals, but I'm seeing more efforts to sort of bridge that gap and fully recognize that there are things that need to happen even before a patient reaches the hospital, and definitely after they leave, that needs to happen in the community.
And so whenever I get a chance to speak with, gurus and power players in the maternal child health space, I always like to sort of end the conversation with a discussion on how do we bring back the joy and anticipation of birth in the Black community, because we've been seeing these numbers, we've been seeing these exposés on, in the media and seeing these articles come out. And so I find that a lot of my patients that I see are afraid. They're like, I want to try to pick the best person. I'm not really sure how I get to that person, or, if I'm going to survive the birth. I remember being in my office maybe about close to a year ago now. And I asked the patient about, has she been considering her birth plan and how she wants to see her birth? Like, has she been kind of creating some ideas around that for her? And I was thinking she's going to respond, oh, I want to try to get on the birthing ball or be able to still get up and walk around and have free movement, or I want to have low lighting. Her first response to me was, look, I just don't want to die. And I thought, wow, how heartbreaking, because the things you should be able to relax and think about and consider for your birth, the only thing you're considering is, can I survive, versus how can I make my birth a joyful, peaceful, empowering experience. So what are your thoughts around that? And how do you kind of help guide people back to making the birthing experience something to anticipate with joy versus being completely afraid of all the data that we see constantly streaming?
That's a really good point. And I think, the theme for this year's Black Maternal Health Week is focused on body autonomy and joy. And I think when we talk about, impacting maternal mortality, that's the floor. That's the bare minimum. Keeping people alive should be the bare minimum. What we should be shooting for is for people to have joyful births, to thrive, to have, complete satisfaction and not be traumatized by the birthing experience. And there's so many examples across the country that I think we need to elevate and highlight. For all of the mothers who die in pregnancy, there's so many more that have successful and beautiful births and successful pregnancies. And I think it's so important to shine a light on the things that are working. One of the things that I love to see some of our Black-owned care environments and businesses that are providing that, fulfilling and, full circle care for Black families. I think about Choices in Memphis. I think about, Community of Hope in DC. I think about the work that Jenny Joseph is doing as well in Florida. And there's so many other examples. I know Uzazi Village. I mean, there's so many places where Black people are celebrating and supporting each other through this maternity journey. And I think this is a great opportunity to celebrate that, to show examples where things are working well. I think about Root in Ohio and other opportunities where communities are surrounding moms, they're supporting them fully, they're getting good care, they're getting access, they're getting education, they're getting support. And to be able to share the successes from these instances And then ultimately to find ways to scale up these communities that are really fully embracing thriving in motherhood among Black mothers. And this is an opportunity during this Black Maternal Health Week to shine a light on all of those opportunities for joy and celebrating bringing in new life.
Well, thank you so much for taking the time to talk with us today about this important subject. It's something that I am definitely very passionate about. And you were the very person that fueled that passion many years ago. Mm-hmm. And I think that the work that you're doing is absolutely phenomenal. I've continued to follow you since I was in residency. And so I'm just so excited that you could make it to talk to us about this. I know you're so busy, but I would really love to continue some of the conversation as we start to develop some of these solutions and put them into action. So thank you so much, Dr. Henderson. I so appreciate it.
Thank you so much for having me. And while I don't consider myself a guru, I do consider myself one of the soldiers in the fight. And I'm always excited to meet another soldier and work along with the rest of the soldiers across the country who are working to end this problem. And along with that, it's been a joy working with you and seeing with all that you're doing as well. And if we all pull together, y'all, we can solve this problem. We can.
I absolutely believe it. All right, girl gang, I know you've learned a lot today. We will catch you on the next episode. Peace.